I'm now looking for Nanaimo General Hospital.
There's 10 of us here. Hi,
I'm sorry, how many? 10? Okay, thank you.
And I'm Lisa, an OT at the hospital. I have a question about, in your screen and assess algorithm, it says when people aren't admitted to acute admission, then they're supposed to get a comprehensive medical, functional, and cognitive assessment. Who would do that, and is that being missed currently?
Yeah, that's, again, one of those implementation questions we've been asked recently, and it is a good question. It starts to get more complicated when you try to get into the who's going to do what. And I think I would urge all disciplines and people involved in stroke care to be flexible with their practice boundaries and to realize that there are some definite overlaps. So a comprehensive assessment may be able to be done, for example, by an OT who has had some experience in rehab, plus a physio or a combination of 2 or 3 people. Or if you happen to have a physiatrist there, then obviously that's somebody who can do that as well. I know that, for example, some centers that do not have access to even OTs or SLPs will then have to rely on nursing to look at doing, for example, a basic swallowing screen, that kind of thing. So this is where, the details of the implementation will have to be looked at in terms of what resources you have and what kind of training they have. And we're going to try to tackle this a little bit from the hyperacute end in terms of what are the actual necessary tasks that need to be done as opposed to who is to do them. As long as they have the skills to do them and do it appropriately in a standardized way, I think it matters less what exact disciplines they come from.
Port Alberni.
Hi there. There's 10 of us in the room, and we just had one question. We were curious about sort of a ongoing funding model or what strategy the actual BC stroke strategy might have, because we recognize that the health authorities are challenged financially, and there's best practices around stroke coming forward. There's best practices around orthopedic conditions and many other priorities, and we're just worried about sort of the ability for health authorities to even move down some of these paths, and just wondered if you had any insights on funding models or...
I'm certainly no expert on funding models, but I think that from what I've seen of the research and what other people have been doing and the data, I do think that if we follow best practice, we should end up with an efficient system that would prevent people from actually requiring greater resources down the road or getting duplicated resources or inappropriate resources. And ultimately, that should save the system money. Now, whether or not the health authorities are able to recognize that and reconcile that is a different matter, but I think that's where we're encouraging them to go. So, for example, at GF Strong, we're recently looking at developing an intensive day program specifically to help people get out of the inpatient stage a bit sooner, and that would then save the health authority money in terms of not having patients stay in hospital, and it would save on some of the nursing costs. So those are the kinds of things I think we need to look at in terms of being able to financially implement some of the strategies.
Thanks, Jennifer. And I must say that this type of work is so helpful for us to move forward within our own health authorities, because a lot of this are things that we talk about and we try to advocate for. And so having some strength behind it through the work that your group's done, just as the musculoskeletal group is doing similar work, it does really carry some more weight that we can use when we do advocate for changing our system to better meet the needs. And I agree that it's always that challenge of the one-year funding model that, there may be some upfront costs, but in the long run, we will save the system some bucks, and that's sometimes hard for people to agree to put that at the beginning.
I would encourage any of you who are potentially looking at implementing some of these changes to have a concrete outcome measure that you can show sort of before and after, so that you can convince the funding agencies to continue with the model, and that showing that it is actually a worthwhile way of proceeding.
I think, too, it would be great if we could keep connected amongst the health authorities. So if someone is implementing something to do with what's come forward through your model, that we can share that success and then help to advocate for it within our own health authorities.
Mm-hmm. Yeah, that's a good suggestion. Thanks.
Victoria General Hospital.
Hi, Diane. It's Heather Gibson here. There was 13 of us that were present. And a question that I have is whether, if Jennifer can comment, and thank you for your presentation, is there an optimal time frame around the maximum amount of recovery we can gain from a patient attending a multidisciplinary rehab program? I'm thinking particularly on an outpatient basis. The challenge of, is there an optimal time? I understand literature saying we get them in sooner than later, but, is there like a window of opportunity where if we've missed that, is it like a 4-month, 6-month window of opportunity where if we kind of miss that with our outpatient resources, we don't maximize the amount of gain? We struggle with the wait times and getting people in sooner, and if we get them in later, what happens?
Mm-hmm. Yeah, that's been an often asked question. Now, I was hearing through the grapevine from the recent Stroke Congress in Quebec City that to truly maximize, you're really trying to get people up into a program within the first, I would think, 2 or 3 weeks post-stroke, and that's fairly acute. Now, it doesn't mean that if people start their program after that they won't improve. It just if you really wanted to maximize your potential, you would want to get in that early. People certainly do still improve even at the chronic stages when you get them into certain programs. And, even if it's not for necessarily neurologic recovery, there are certainly some functional gains to be made. And I think also a lot of the literature around recovery has been centered around motor recovery, which is easily measurable. But a lot of the other recoveries in areas of things like speech, sensation, cognitive status, we really don't have very good timelines as to when that starts to tail off, and certainly people have seen recovery even sometimes years after stroke. So a lot of the stuff that are quoted in literature for recovery is specific for motor recovery.
Okay, thank you.
I want to thank all of you for your participation today, and particularly Dr. Yao, who I think really did a wonderful job of explaining something that is not easy to explain in not very much time. Also, I want to acknowledge the consultant, Linda Ross, who has now left, who really did the lion's share of the work in supporting the group in terms of developing the rehab and reintegration framework. And I just want to remind you that this presentation and recording will be available on our website at www.bcstrokestrategy.ca, and remind you also that the documents can be downloaded from our website at the same website. So goodbye, and thank you again for joining us.